So, hi everyone. Thank you so much for coming to our event today, the Medical Herstory collab with the Thrive Collective entitled Living with Chronic Illness. So, we're really excited to have everyone here. And today we'll be delving into sort of how chronic illness is often invisibilized, unbelieved, or undiscussed, especially for femme-presenting people. We're here to challenge these notions by showcasing our own stories and encouraging these conversations throughout this event, as well as long after it ends. So my name is Tori Ford, and I'm the founder of Medical Herstory. We're an award-winning international nonprofit advancing gender health equity through storytelling and undoing stigma. In the last week, our team has expanded over 6 countries and 12 universities, where we publish creative nonfiction pieces written by women and femme-presenting people, as well as people just across the gender spectrum who've experienced sexism within medical care. We hold workshops and events like this to raise awareness on gender inequity and to foster community. So for this event, we're partnered with the awesome Thrive Collective. So they provide support for people living with chronic illness and disability within the McGill community. And they're actually the producers of the docu-series Thrive that we're going to view today. So we're really excited to be able to showcase this film for the very first time. So a bit about our schedule today. This is just a bit of an overview. Very shortly, we're going to provide a link to the YouTube channel where you can watch our film. That'll be around 30 minutes in total. And then afterwards, you'll come back here so we can have a panel discussion as well as an audience question and answer period. The panel and Q&A will be recorded, but if you'd like us to remove your questions or anything, just let us know. And some Zoom rules throughout the event. Feel free to have your camera on, but please keep yourself muted until the end, unless you're asking a question, of course, just so that you don't interrupt the movie. Lastly, but not least, throughout the event, we'd really love to hear everyone's thoughts. So we've set up an interactive Google Doc where you can answer 2 of our questions. We want to know what comes to mind when you think of chronic illness before and after viewing the film, and what role does storytelling play in your own experiences of health and illness? So I'll go and post that link now. And before that, I'll just pass it over to our amazing collaborator, Sloan, who's going to tell you a bit more about what to expect from today.
Hey, I'm Sloan. I'm Tori's co-host today. So I'm a short-haired Asian woman wearing a red t-shirt, and I'm the co-founder of Thrive Collective McGill, a social support and advocacy group for students living with chronic illness and disability. I'm also the filmmaker of the short docufilm that we're going to be screening today. Okay, so the film is filmed in Montreal on the unceded territory of Kanien'kehá:ka people. The island is also known as Jodargay. The island is I like to think of it as the big canvas where all the stories happened. You know, it's in every scene and every conversation we're gonna see in a film. So our reality is deeply intertwined with the context of colonization. So I wanna encourage everyone to seek knowledge on colonialism and local resistance. Now the film. We have shared the link in the chat to a YouTube playlist where you'll find 4 parts of the short film compiled. All 4 parts will play back to back, so you can turn on the closed captioning by clicking the CC icon at the bottom right of the YouTube video. And there's no need to leave the Zoom call, just open the link in a new window. Though this is a virtual event, we do like to remind everyone that we want the space to be about care and support of yourself and each other. So take deep breath, keep an open mind, and stand up and stretch when you feel like it. So after the film, please meet us back here for our panel discussion. Our 3 panelists, in addition to Tori and myself, are Harleen, Adrian, and Caroline. Okay, now please click on the link and we'll meet you back here in 30 minutes.
So yeah, I hope everyone enjoyed those films. I just want to give a shout out to the Thrive Collective. I think they're absolutely amazing. And we actually have Harleen with us here today who's on our panel. We saw her story, which is just beautiful. And that poem is something I rewatched before having seen it so many times. So we can definitely share our thoughts. We have our collective Google Doc going. I saw some people were saying some really great things there. So if we want to just keep updating that throughout the rest of the event, that'd be awesome. So our panelists are going to go through and introduce themselves, and I'll start. And then after our panel, we're going to have that question and answer period. So if you do have some questions, I just ask you to keep them until then. My name's Tori, if you didn't know that already. I'm the founder of Medical Herstory. It's our nonprofit advancing gender health equity through storytelling and undoing stigma. And the project was born out of my own experience with chronic illness and just facing sexism and neglect within healthcare. So I created this platform to be a site for criticism and healing and to showcase stories like the 3 we just saw today, as well as many others. And in addition to my lived experience, I also hold a BA from McGill in Gender Studies and an MPhil in Health, Medicine, and Society from the University of Cambridge, where my work focuses around experiences of chronic yeast infections. So I'm an outspoken women's health advocate, and I'm very excited to see you all here today. And now I'll turn it over to the rest of the panelists to introduce themselves.
So I'm going to start, but before that, I just want to apologize to Harleen because I just noticed that in the film, your last name was misspelled. So it should be Bogel. So sorry about that. So I'm Sloan. I go by she, they. So I'm currently in my last semester at McGill, finishing my bachelor degree in international development studies. I co-founded Thrive Collective with Nancy Wu, who's also here today. Though I have been chronically ill for more than 10 years, my interest in chronic illness and disability advocacy really started when I attended an equity workshop given by Rachel Desjardins a few years back. And I have been doing student activism work since then. People are sending me private messages, and I also see people are typing in the collective notes. I just want to say, as a filmmaker, I'm so happy to see that, and I hope you have a great time here. So we'll go to the next panelist.
So my name is Adrian Pigott. I've been chair of the subcommittee for racialized and ethics persons since I think my first months as an employee at McGill, but I actually grew up at McGill, so I've been there since I was about 8 months old. My dad's a prof. I actually was born into my illnesses. I have 3 congenital illnesses that were diagnosed over the course of my life. But I've often spoken about the difficulties I encountered, in part because some of my illnesses were only discovered after I was born by the medical field. So for most of my childhood, my parents were told that I was essentially making it up, which led me to spending a lot of my time after those years discussing how children, but in particular brown girl children, are treated by the medical establishment. But honestly, I'm really just excited to see how many people have decided to spend part of their Sunday here with us to talk about this, because I think a lot of people forget that it's not the same experience for everyone when we interact with the systems that are currently in place. I also give a workshop on racialization and crisis intervention to talk about how people who are in crisis experience professional interventions differently and why the outcomes are not always as they should be. So this is a really, really wonderful experience for me to be here and to share this with all of you. So I really appreciate the invitation. Rachel is the one who reached out to me and asked me if I would like to be a part of this too. So she's a wonderful advocate on campus. For those of you who don't know her, she's absolutely brilliant. We are co-chairs because we are all sitting members of the university's larger committee on equity. So she and I work together often, and I'm a secret member of her subcommittee as well.
I'm Carolyn Marcione. I'm an assistant professor at the Ingram School of Nursing, the university at McGill. I also have a part-time position in ambulatory oncology at the MUHC. I work primarily in palliative ambulatory care and radiation oncology. I've been at McGill full-time for 4 years now, and one of the reasons why I joined the faculty full-time rather than keeping a full-time clinical practice is that my own chronic illnesses do not permit me to do so. Definitely in the context of COVID, that is not a good thing. For me, I've been chronically ill with severe asthma and related conditions, including a immune deficiency since I was 23 years old. So that now makes it 20 years. I teach courses on chronic illness and palliative care because, those who can't do teach. And I think my faculty decided that they should put the sick one in charge of that course because I might have had something useful to say.
My name is Charlene Bogel. You got to learn a little bit about me through my film, so I'll keep my intros short. I'm really happy to be here. Also really grateful for those very sweet messages in this chat. As I mentioned in the video, but I'll reintroduce myself. I work at the South Asian Women's Community Center currently. I've been a youth worker for since 2013. When I finished my degree, I love my work and work a lot with students, or high school age students, with struggling with mental health as well as all sorts of things. And it's funny. You got to learn a little bit about my experiences through the film, but what I'll add is the film was made like a year ago, I think. It was like filmed last year, and it's amazing how I feel like a lot of people anyway with chronic illness and who have multiple chronic illnesses their lives will change a lot from one year to the next, or from like a decade to the next. So I was thinking back to when the film was filmed, and how I was having IBS flare-ups that time, and fatigue flare-ups and all of that. Whereas currently my IBS is under control, but I have really horrible my sinusitis is flaring up. And it just I think it just even proved to me again that chronic illness is also not so clear cut. Just because something's written in my file 10 years ago, or 1 year ago, or 6 months ago, doesn't mean it's gonna be the same. And that's why a healthcare adequate follow-up is so important.
Thank you all so much for being here today, and thank you for the wonderful introduction. So without further ado, let's start our first panel discussion. So my question is, what sort of power does sharing stories of chronic illness, like this film or on social media, hold for each of you? So I guess I can start. So actually, instead of the what, I wanted to talk a little bit about the how to share stories to make it powerful. So to me, I think the power lies in both the narratives and the practice of narrating. So at the very beginning of the filmmaking process, before we had a script, before we even started shooting, I decided that the film is not going to be about raising awareness. My only goal is to empower the participants in the film, not that they need any help realizing how incredible they are. So that in translation, I will not ask them to share anything they're not comfortable sharing. Their well-being is always the most important thing to me, more important than how the film turns out. And the schedule will, it was totally up to them. They can reschedule anytime, they can drop out of the project anytime, no questions asked, because it's their story, right? So I think we call ourselves filmmakers, but we don't really make the film. We don't really make the stories, right? So from my perspective, the power of sharing really came from behind the scene. And surprisingly, I think that beautiful connection and trust between me and the participants really paid off. But I'll leave that for the audience to decide. And also one little story behind the scene. So at first, Emi was going to be anonymous in the film because at the time she was actually applying for jobs, and she was, afraid of the potential discrimination in job applications. But while we're shooting the film, one day she came up to me and she told me that we can actually put her name on the film because she felt the film is not about her weakness or illness. It showed her as such a strong, amazing, and young woman. So I, as a filmmaker, I love that moment. So yes, I think to me that's power. As to how powerful or empowering it is for people watching it, I try not to think much about it, at least not too much about it.
I can certainly speak to how the sharing of stories, it was impactful for me. So just to preface this with what my illnesses are. So I have a congenital blood clotting disorder called protein C deficiency. There's several different kinds of protein C deficiency, and I have the one that is considered to be the most severe. I also have a kidney disorder called thin glomerular basement membrane nephropathy. So it's a collagen bond disorder, which causes the collagen bonds to be weak. So one of my kidneys is malformed and upside down and doesn't actually work fully or even particularly well, and it bleeds almost constantly. And then I have a neurological disorder that makes, it's kind of like the intersection of epilepsy and migraine. So I have these things called hemiplegic migraine seizures. So it looks like I'm having a stroke. I'm not really having a stroke, but it can look like I'm having a stroke. When you have a blood clotting disorder and something that looks like you're also having a stroke at the same time, it can cause a significant amount of distress, both for your carers and your family. But those are the three conditions that I was born with. But hearing other people's stories and why that's been so impactful for me was growing up, because especially my blood clotting disorder was actually not known to the medical community until 1984, and I was born in 1972. For the first several years of my life, people telling my parents that it was psychosomatic, that the pains I was describing didn't exist or were in my head or were caused by all kinds of other things, I began to believe that nobody else, or that the pain I was feeling was one of those things that other people might be feeling but never talked about. And once I started hearing other people's stories of their illnesses and the descriptions they had of not being believed, and it taking years to finally encounter the right physician who accepted that their story was real and committed to finding the actual source of their illness, it really was a game changer for me, because I spent years believing that everyone else lived with significant amounts of pain and just didn't say anything, because clearly when I said something, I was being treated as though I was making a fuss over nothing. And it took so many years for me to finally accept and embrace that I was in fact not, suffering from a different form of illness, namely some kind of delusion or a mental health crisis, but I was in fact experiencing real pain in my body caused by a physiological disorder that no one was addressing. And it actually took until I literally almost died. I had a pulmonary embolism at the age of 15 after having a large deep vein thrombosis. That's a major blood clot in one of my legs. That went undiagnosed for 10 days as my leg proceeded to swell to the size of, well, by the time they finally recognized what it was, my leg had a foot at the end that looked like a football with toes. That's the point at which someone took it seriously enough to figure out what it was. And then the clot separated, part of it went to my lung. I was officially, in crisis, because the mortality rate for pulmonary embolism is about 70 or so percent. So that's the point at which someone decided clearly I was not making this up and there was actually something wrong with me. And that's when I was diagnosed. But hearing other people's stories is part of what empowered me to just keep insisting and going back and going back and going back to the hospital and saying, I don't accept you're dismissing my crisis. There's something wrong with me. So I definitely appreciate all the filmmakers and all the brave souls before me who went out there and said, nope, I'm definitely ill and you're not doing your job by dismissing me. And the filmmakers who brought those stories to light, because that allowed me to feel confident in my voice and continuing to push for the care that I needed. So definitely that's the power of those stories for me.
Yeah, the gaslighting and the minimizing that folks go through, I think across the board, like you don't even have to have a chronic illness, but just like so much gaslighting of people of color and women in the healthcare system. And I do, and that connects to what I was going to say also, with why I think sharing stories are powerful, in that like we have systems in place right now that very intentionally is erasing these stories and marginalizing these stories. Capitalism doesn't want people who are complex and human and are in pain. It wants people who are constantly being productive and turning the wheels of the economy. And so in that way, sharing our stories becomes almost a resistance to these powerful systems. I think more people are struggling than we know. I also think it doesn't take much for us to realize people are struggling. People are expressing struggling every single day, and chronically, that they've been struggling for years, either with physical health or mental health. But I also think because of all the stigma and all the minimizing and gaslighting, a lot of people keep it inside. And also people with chronic illness are punished for having chronic illness. I mean, they're systemically punished, like lower employment levels because there's not enough accommodations in workplaces for folks who have chronic illness, increased poverty, the risk of poverty, like the worsening of illness for folks who do work and aren't able to attend to their symptoms, can have very dangerous, if not fatal, consequences for people. And then just like being gaslighted, being minimized, not being heard, not being able to access education. I mean, I saw in the other short films just everyone struggling with education, and definitely there's people who just fall through the cracks of education because of their chronic illness. And I think the more we share our stories, the more it brings to light that our current economic and social structures do not accommodate for just human beings, because so many human beings are struggling chronically. Yeah, what are we prioritizing then? And I think we're prioritizing other things rather than the health of our society, because people make up our society. And then the last thing I always say, like when I think about my work with the youth and my students, the students I work with in high schools and stuff, is sharing stories is crisis prevention, and it's suicide prevention. Not being heard or not being seen has fatal consequences a lot of times.
I shared in the chat an article, I believe it's from JAMA, talking about the movement towards narrative medicine, which is a little bit what we're talking about, in the idea that as a healthcare practitioner, you elicit the patient and a family story in order to really get at their lived experience of what they are going through in order to better address their care needs. And I think, so I have a little bit of a different perspective on it, because I see it from both sides of the coin, right? I guess 3 sides of the coin, because I see it as an educator, I see it as a patient, and I also see it as a healthcare professional. And I think, and when I was reading, especially on the Herstory website, a fact that the gender inequalities that women experience, and I never ever thought that any of my shitty care that I received was related to the fact that I was female. I thought it was because I was getting shitty care. And if I was getting shitty care from one healthcare practitioner, generally speaking, that person handed out shitty care to everybody. So I didn't think it was ever related to me and my gender. But academically, I do know that there are major gender discrepancies in care. For example, women are notoriously underdiagnosed when it comes to myocardial infarction, et cetera. So that being said, I don't have any gynecological conditions, which draw sort of my sex into light. Sexuality is generally avoided and not contemplated when it comes to chronic illness in general, be it from male or a female. It's just not something on the radar. And I, as a practitioner, I would hazard that that the system in which we are thrust, the healthcare system, does not allow for this in-depth holistic assessment and understanding of the patient experience, because there is a dearth of resources. And I'll give an example. So if you're an oncologist and you have to see 40 patients in 3 hours in order to get everybody to have some chemo for their life-threatening illness, we don't really have time to start talking about, how are you feeling and how are things with your partner. the role, it's very, very sort of, if you look at Maslow's hierarchy of needs, we're very low on the totem pole of Maslow's hierarchy. I'm very fortunate in my clinical practice, because it is end-of-life care, it is palliative care for patients with advanced cancer, we have a lot of time to sit and talk with our patients. And so that is where I really can elicit the health narrative, the family narrative, and really get at strengths that the situation is presented that people don't realize that they actually have. And so that's the model of nursing that the Ingram School of Nursing has adopted. It's the strength-based nursing paradigm, whereby patient, family, and communities' strengths are advocated for, and our role is to put the patient and family and community in their best possible condition in order to optimize natural healing. So if I put you on a ventilator because you have COVID, what I'm really doing is I'm supporting you while your body does its inherent healing that we hope you can do. So I think that a lot of it is not due to sort of voluntary malfeasance or neglect on the part of healthcare practitioners. Healthcare practitioners are very, especially physicians, are trained to diagnose and treat. When the condition does not fit nicely in a box, and you are a zebra, Adrian, you are a zebra, and that's okay, right? But physicians and nurses are trained, when you hear hooves, you think horses, you don't think zebras, right? And so you're like, hey, but I'm not a horse, I'm really a zebra. Then everybody kind of looks at you funny because it was like, that's not a thing. Like I learned about that in my textbook, right? But yeah, I am the thing that you learned about in your textbook, or that they're certainly just researching, right? And so you're the thing with like the life behind it. And so being a zebra is, and I'm a zebra as well. And it's sort of like, well, you have asthma, why don't you take a puffer? I'm like, listen to me, I'll take a puffer, okay? It's a bit more complicated than that. So when you're on the severe end of any of the chronic illness spectrums, that's where people don't really know what to do with you. So either you're on the severe end and traditional treatments don't work, or you have some weird thing that no one's either discovered yet or identified, then you're going to be treated a little bit weirdly too, because nobody knows what to do with us, right? And so the idea is that you want a clinician, and you have to cherry pick them carefully, who is open to just treating you as a human in front of them and your story, right? So yeah, I don't know if that offers some clarity, but storytelling is incredibly powerful. I teach with stories. I don't necessarily teach my own story. I teach with patient stories. And I think the fact that I'm a clinician as well really improves my teaching, because I get to go back to class and say, hey, let me tell you a story about patient XYZ. And I think novice practitioners really learn from that. So I think it is something that we as healthcare teachers can definitely learn from.
I'm just going to jump in briefly because, Caroline, I think you and I are similar in age as well as being on the similar end of the chronic illness spectrum. Because I had a very very interesting and telling experience for me. And when I really recognized that there was clearly something beyond just I'm an oddball in my category experience. So I was treated for a long time on the children's end. So I was at the Children's Hospital, Montreal Children's Hospital for the first several years of my treatment, and then transitioned over to the Montreal General Hospital when I aged out of the children's. And I actually had my first hematologist break up with me the way a romantic partner breaks up with their partner. Literally the whole "it's not me, it's you" conversation that he had with me. And the conversation went that way in large part because I insisted that he have conversations with me at every meeting we would have. And in the beginning, because my protein C was difficult to control, they weren't used to prescribing those kinds of anticoagulants to people my age in the doses they needed to keep me at the right therapeutic levels. I had to go to the hospital In the beginning, it was 4 days a week. So I literally had to go in to have my, at the time, it was PT, PTT, now INR done every morning, Monday to Thursday. So I would go in and have it done. Then the physician would call me and tell me what my dose for the day was. And at one point, he would tell me, literally when I would walk into his office, have your father call me and I'll explain to him what's going on. At which point I would tell him, I am an adult and my father is not your patient. He said to me, you won't understand. I explained to him that I'm the one who's been treated for this illness from the beginning. And in fact, my father was on sabbatical in BC and had to fly home to be with me when I was first diagnosed and treated. I'm the only one who's been with this illness in my body from the beginning. The person you need to speak to is me. He found me belligerent, he said. And he could not be my physician because I was difficult to treat. And so told me that the person he would either speak with is my father or I needed to find a new hematologist. So I did. I told him, I guess we are done. He went, yep, I can't treat patients like you, he said to me. And that was it. I had to find a new hematologist because I decided that he had to have conversations with the adult me and not my parent. I'm not convinced that he would have had that same conversation had I been a male. And I'm certainly not convinced he would have had that conversation had I been a slightly older white male. I'm fairly convinced he had that conversation with me because I was a young Black girl. I don't have another explanation.
I mean, that's, you could report them to the college because you don't get to talk to your patient's parents without their express permission. That's called patient confidentiality. It's a thing. After you're 14 years old, your parents are like excused from the equation. So that was just wrong on many levels. You're like, you know what? Actually, I'm breaking up with you. Bye. It's like,
Yes.
you're like that. You make no sense. Like,
it's 31 years ago. I'm over it now, but yeah.
Well, thank you everyone so much for your answers and sort of the honesty and rawness that is coming through with them. So obviously in my role at Medical Herstory, we're all about sharing stories in this sort of just like raw, honest way that we don't often see. And I think for me, chronic illness, in my case, chronic sexual illness can feel a lot just like losing control. You don't really know what's going on with your body, especially when you're young and more at the beginning of your illness journey. And especially as a young woman, you're really scared of being seen as being overly emotional or just not believed when you're trying to express your pain. So I think that sharing stories like we sort of touched on is a way to get our power back and be able to sort of express our feelings of being frustrated and overwhelmed and confused and sort of process that and also form communities. Because like we've been saying, when you're chronically ill, it's sort of that you're supposed to go to the doctor and they're supposed to have answers for you. But in reality, you have to go and sort of bare your soul of the narrative of what's been going on in your life. And if you've been bounced around, you sort of get used to this process. And then 10 minutes later, you're on your way home. So I feel like stories are a great way to sort of capture where we're in the moment. And also sort of like Harleen touched on at the beginning, sort of track sort of where you're at and what's going on, because it can often be such a tumultuous journey. But I think that through reclaiming our narratives is sort of how we build community for ourselves and then remind others that they're not alone. So with that, I think we're going to move on to our next question, which is, given the dismissal people living with chronic illness often face at the hands of the medical system, what could help improve dialogue between physicians and patients when it comes to chronic illness? So I think one of the problems that we've already sort of touched on is that the system's really made for acute conditions, and that once you're chronic, there's not really a support system in place for you to be cared for. And I think that's sort of why we turn to communities to sort of fill those gaps. Because yeah, when you don't fit into a neat box, you sort of don't get the continuous care that you deserve. Especially if you're dealing with something like, in my case, chronic yeast infections are often dismissed as like, it's normal, it's benign, it's not that serious, just go home. But after 4 years of living with it, it does take a toll on you. And it's hard when what you're living with is recognized as normal, or like we've been saying, is recognized as being the zebra in the mix of things. And I feel like some of the solutions to these are physicians starting to recognize that patients are the experts of their own lived experience, and sort of recognizing how difficult it can be to bear yourselves being vulnerable and sharing those stories in the moment, and knowing that you might just be like, you're basically risking that you're going to be dismissed and sent home. So I think at the core of it is just believing patients, coming up with long-term treatment plans, sort of telling them, we're going to get through this together. We're going to figure it out. We're going to get to the bottom of this, which I've personally never had. It's more so like, oh, go see someone else. I can't help you. Or, oh, it'll go away on its own maybe. Or, oh, it's not going away on its own. Well, just learn to live with it. And I think because of that is what happens is we often just fall through the cracks of the current medical system.
I totally hear what you're saying. I think in my case, for those of you who can't tell, it's Adrian speaking again. What I decided was that I was responsible for my care. And I think about the amount of effort and energy we put into shopping for all of the other things that we bring into our homes or into our lives that matter to us. And I decided that my care was more important than all of those things. And I was entitled to do that for my care as well. So I actually, over time, curated my own army of physicians. I have the neurologist that I want. I now have the hematologist that I want. I have the nephrologist that I want. And I, was not afraid anymore to tell physicians, this isn't working. We are clearly not compatible. I need somebody other than you. Because I found that by letting them make all the decisions, I was sort of abdicating that role in my own well-being and my own wellness. And it matters to you who is taking that important step in your life. I don't get to prescribe my own medications. I don't get to call for my own tests. Someone else does that, but I have to trust that person because it's a really big deal. So at one point, my neurologist almost became my primary care physician because he was the one physician I had at that time that I genuinely trusted. And through him, we built the other, the army of other physicians who now look after me. But I chose the doctors who take care of me because it's not their body, it's mine. And so I should have that right. And I think that that's how you really make sure that you're receiving the care that you need. It's okay for you to tell the physician, I'm not comfortable with what you're telling me. I don't agree with the decision you're making. That's not the path that I'm, comfortable going down. I need to talk to somebody else. You can say all of those things. The physician doesn't own your care or your body, you do. And that's how I think we make it better, is by allowing people to have that agency. And if they won't allow you to have it, then just take it. It's your body to control.
I think, Adrian is bang on. I have the same thing. All my care, I have a list of specialists, and they're all cherry picked. And when I need a new one, because I have some other thing, then the first question is, okay, but how are they in their bedside manner? I don't care really about their expertise in XYZ. If they are inadequate in that end of the thing, thank you very much. Or it's like, listen, the person's like this, but it's, but they're really good at it. And I'm like couched in that understanding of how that person is. And then I can sort of like temper my, my interactions with them. But so when we talk about privilege, privilege comes from being white. Privilege also comes from being educated, and privilege also comes from working in the healthcare system. So if I need a scan, I take my paper over to the MRI department and be like, hey, scan receptionist, can you book this for me? And then it's done, right? So that is privilege, and it's not supposed to be like that, but it is. So I think that's also something that the conversations I have with my healthcare practitioners are a bit different than the level of complexity that is done with the average patient. And I don't want to mean to, denigrate the average patient, but when I write patient information documents, I'm instructed to use grade 4 language in order for everybody to understand. So if I'm given a pamphlet about XYZ condition in grade 4 language, I'm like, no. It says, hold on, let me do a PubMed search and we're going to talk about this properly, right? And then the conversation changes. So, but you only get that when they really know you and who you are. And then you get a more collaborative sort of decision making. 2 years ago, I was intubated in the ICU, and it is sick because I had a massive pneumonia and things were not going so well. And the decision to intubate me was made with me. So it wasn't like, okay, now's the time. It was like, okay, 2 o'clock, that looks good for everybody. I'm texting my family. Okay, this is happening. It was a collaborative decision, not made by my physicians, made with me. So because I was then going to be out, which I was out, and so yeah, I think it's very challenging when that is what the power, I think, differential comes from. It's a little bit about the differential in knowledge. And if you can speak the same language and talk the same language as your care providers, it changes the dynamic a lot. And that's privilege, really.
I also want to tie in power dynamics that come from having social power. So intersectionality as well, like the intersection of gender, race, class, sexual orientation, sexuality, et cetera. I don't think our healthcare systems are designed to support people who are marginalized. So whose physical and mental health intersect with oppression, systemic oppression. So prejudice, discrimination, systemic violence, systemic racial violence, systemic transphobic violence, et cetera. I don't think our health systems were built from that perspective. Our healthcare system was born in a system that is run by white supremacy and colonialism, settler colonialism, and it's obviously going to serve and prioritize certain needs over others because of that. It was born out of those systems of power. I definitely felt as a woman, and maybe a woman of color, I mean, it's hard to tell sometimes why you're what's happening there, but I do think women's pain is, I mean, this has been also reported that women's pain is severely minimized, as well as people of color's pain is severely minimized in the healthcare system. An example that comes to mind that I didn't really get to talk about in the film, I mean, again, the film was only 10 minutes. I have endometriosis, or at least maybe, haven't gotten a diagnosis yet since the age of 11. But since I was a teenager, every time I get my period, it was just horrible, not just cramps, which were bad enough as it is, but head to toe migraines, back spasms, swelling of different joints, including my ankles, fainting, vomiting for 5 days, and I tried to self-advocate and went from professional to professional, gynecologist to gynecologist, and the number of times I was told, oh yeah, that's just like menstrual pain, that's just menstrual cramps. And if that's true, then that's horrible. We need to figure out what's going on there, because I am not functional for 5 days every single month. And again, as I answered before, you're punished for that through lowered employment, like threat to employment, threat to schooling, all of that stuff. I'm also bisexual and also a survivor, and I know how there's a bias there when I interact with gynecologists, and that's just one field of the healthcare system. So I do think that our healthcare system just it needs complete reform if we're gonna actually build it to also serve marginalized folks appropriately. At a less systemic level, I think increased communication between specialists. A lot of the previous panelists described having different specialists when a new problem comes up, which will often be the case with chronic illness because our body is one. And so different organs are working with different things, different other organs, and our brain is in our body too. There's no communication between my specialists. I mean, and all of these chronic illnesses affect one another. They're working together. I mean, I'm sure my IBS is tied to my anxiety, but no one's figuring that out. And so the system's not really built for a more holistic care. I also think that prevention and holistic care would go a long way to just preventing illnesses from getting worse, and for people, for example, ending up in the ER. I described in my film that my asthma was not even diagnosed until I had a near fatal asthma attack, and the reason is because my doctor knew I had anxiety and was like, well, that sounds like, I don't know why she didn't check my lungs or assumed that that wouldn't be the case, that I had asthma. But in any case, I ended up in the ER, which is extremely costly to the healthcare system. I know, like, I worked in the healthcare system as a social work researcher, and I know that the ER cost is a very costly part of the healthcare system. But I did not need to end up there, and other people don't need to end up there. And also, it's like very traumatic to go through life-threatening events just because that prevention and holistic care didn't happen to begin with. I think dialogue between physicians and patients won't be improved until systemic power is taken into consideration, as well as not looking at the body and mind holistically.
We do have a proclivity for a reductionist view of the human body. This is just the way bodies are, we view. I mean, look at medical specialization. You specialize by organ system, right? So if it's out of your purview, the nephrologist, he's forgotten everything about, like, the rest of it, because he knows nephrology. And so they become very nervous when they're asked to look more holistically, because the rest of the body, they forget, they don't know. They know about kidneys. Don't ask him about, the heart, because he's kind of maybe thinking about the heart, but really thinking about kidneys, he or she, I should say. And it's so reductionist that, we work in cancer pain, right? And they only want to treat cancer-related pain. So patients often come to clinic with pain that is not related to their cancer per se. So Monsieur has some sort of abdominal tumor with causing pain, but that pain is not as bad as the pain in his knees from osteoarthritis. That was a lifelong, chronic condition. And pain specialists are like, well, he should go to the pain clinic. We only do cancer pain. I'm like, listen to me. He has pain. He's here. How about we help the guy out, So, I mean, even pain is cut into little pieces of etiologies, right? So we do not take a holistic view often. And the trick is to find people who do. And so, palliative care is one area where we do, because it's a shame, because you have to wait till you're dying in order to get that type of care. It's unfortunate.
Okay, thank you all for sharing your opinions and stories. And we actually have 2 more questions prepared for this panel, but unfortunately we're kind of running out of time, and we do want to give the audience the chance to ask their questions and also to share what they think. And the thing is, Thrive will also host a sort of after party or after session after this event. So please sign up or just follow Thrive or message us if you want to join us. So we will be talking about some of the questions we talked about today. But now let's go into Q&A. So Tori.
Awesome. Yeah, thank you so much to all of our panelists. It was really awesome. And definitely, I think some of the themes that were going to be in our 2 other questions will come up in the Q&A. So you'll get a chance to speak on that. So for our participants, if you just want to write those in the chat, I'll read them out. Or if you would like to turn your microphone on, just let me know in the chat and I can tell you to go.
You can go.
Hi, Sloan. Hi, everyone. I just, first of all, wanted to thank everyone, Sloan, Emi, Sophie, and Harleen for making the film, and also Tori to help this to get delivered. So I am a non-femme identifying individual, and I feel this, watching this film has been really, it's been a healing process for me. Sometimes I think that as a male, I struggle to really acknowledge my emotions and also to examine my anxiety or stressors, for the lack of a better word. I think that seeing this film really come into life has been very transformative and really touches me a lot. So I wanted to thank each one of you for making this possible. And I also think that from looking at this film, it also really teaches me a lot about how to interact with students. So I'm teaching 2 courses as a teaching assistant. So it's really important for me to be aware and also to be sensitive of the different needs of individual students, and also to just be accommodating as I can. So thank you for that.
So in regards to education, I feel like Harleen mentioned that all 3 of the films had this correlating theme of like struggling with education. And as someone who's like in the education field and I'm trying to get into that more, I'm wondering if you have any thoughts on how we can improve / like dismantle a lot of what like the common educational practices. I'm thinking of like right now during a pandemic, my professors are requiring the same amount of work or even more, and the consistent amount of work every single week, and like participation marks and stuff like that. So like little things like that I feel like really takes a toll on people in general, but I imagine it would be a lot harder with like chronic illnesses. And so if you have any suggestions / like practices that you want to implement if you're an educator, and if you're not, like any ideas as a student in the past to better how to educate people. Yeah.
I can answer first since I scribbled notes right away. What comes to mind is, that I think might be helpful is very concrete. It's like suggestions. Also, yeah, mad at school. I didn't completely read the book, but yes. And this is coming from personal experience as well. I'll just tell a little story where I remember it was actually an Indigenous professor teaching a course on Indigenous approaches to social work. And she basically, she was very accommodating, and that was clear from the get-go, but I didn't really believe her. And so I was experiencing a bunch of shit. And so I often had late assignments and stuff like that. So I went to her office hour once, and and it was the day of a deadline for a major essay. I don't think there was a final exam. I think it was like a final essay as part of the exam. And I remember I went to her and I was like, I didn't do it. I've been having panic attacks for days. I have insomnia. I haven't slept. I cannot write this. And she so casually was like, oh yeah, hand it in whenever. And I remember not believing that. I remember like, no, there has to be some kind of deadline, and there's a chance I won't be able to meet it, but I'll give it a shot. And she's like, no, hand it in whenever. And then I'm like, certainly you can't meet whenever. And then she's like, there has to be some kind of deadline, especially it was nearing the end of the semester. And she's like, Harleen, if the grades have to go in and I need to rewrite your transcript because you handed in post grades going in, and she's like, don't worry about it. focus on your health and hand it to me whenever. And I remember breaking down crying because I was like, you're so nice, but it wasn't about being nice. It's about having this approach that of accommodation and complete flexibility. So that's an example of a story, but I remember studying disability studies and stuff like of how deadlines are ableist. And so being like, this is and you might need deadlines, but being like, this is a deadline, but it's a soft deadline. Obviously come to me if you need to hand it in late. Or if profs or teachers, like high school teachers or elementary teachers need to have it, done by a day, giving folks that transparency, like I need to hand it in by this day, but this is a deadline, but feel free to like take your time. If like there's a midterm assignment, or like in high school, if there's like a term 1 versus term whatever, like just deadlines, challenging this idea of deadlines. And yeah, we're not preparing people for like the real world because the real world has deadlines, but the real world is super ableist. So if we're trying to dismantle ableism in our education systems, deadlines or allowing folks to be late. I mean, my students have in high school do not sleep on it often because of chronic illness and are late because they just like haven't been able to get to school on time. And so being allowed to be late, like in high school, I know my students are super like there's consequences to being late. Your parents are called, and often parents know what's going on, but they get detentions, that kind of stuff. Another thing I think educators, whether it's high school, whether it's university, whatever, is encouraging collaboration between students, sharing notes. Also profs and teachers putting their notes online, not assuming that like everyone A has the capacity to take notes in live time, and B, they might be absent a lot, allowing absences, allowing collaboration with my students. I know in universities it happens more where we all share our notes and stuff like that, but high school, because it's more like supervision based, like it's like students are scared to just like there's no collaboration. So even teachers being like, where, like if you have a friend who's not here, like where, like or like it's just like, I know there's this idea of sharing notes or like whatever, but even on assignments, working together for assignments, why aren't we collaborating a lot more? And I think this would really help. Also, the last suggestion is for testing. A huge intersection between chronic illness and this difficulty with doing tests. Asking your students, asking each individual student in some way, is the way are you comfortable with taking a test the way we take tests? Do you need accommodations? Do you need to be in your own room? Allowing take-home exams or like another way to do testing. I mean, we're in a pandemic and we're still, we're doing everything online now. So all these students, including high school students, including elementary school students who are not given accommodations to study from home. Well, we know we could accommodate that now. It's gonna be a lot more difficult. Obviously, teachers are not like the education system is not set up. Like teachers are already overburdened. They were in hell since the pandemic started, since before the pandemic. And so I think we need more funding into education systems that even makes room for all of these accommodations. But if you can, just like my prof at that university, that one prof at a university who really challenged that idea of a deadline, if you can rebel and resist in that way, these are my suggestions.
Thank you, Harley. I just wanted to speak briefly about my experience in high school because I was sick all through high school. And at one point I actually spent an entire term in the hospital. I was hospitalized for a term in grade 9. And when I returned to school, I actually was like still very much in recovery mode because I had lost over 30 pounds while I was in the hospital. I was a skinny kid already. So when I came back to school, I weighed just over 80 pounds. I couldn't walk. I had, as I said, missed the entire term. And my school was absolutely just above and beyond amazing. And they really embraced my illness and how they would be able to accommodate what I was experiencing. So first, while I was in the hospital, it was a relatively small school, to be fair, but they had actually made arrangements for various students my friends first of all, but most of my grade visited me while I was in the hospital, so I wouldn't feel quite so isolated, because I was going to be bedridden. I was not allowed out of bed at all for over 6 weeks. So students took turns coming to visit me, just making sure I felt connected, didn't feel so isolated, which was really wonderful, especially at 15, which is, it's easy to feel kind of disconnected pretty quickly. From there, when I was returning to school, they actually prepared the most of my level for what I would look like, what I would be able to do, what I wouldn't be able to do, with the information that I provided and that I felt comfortable with them sharing. I had to give myself my own injections of a certain medication during the day. They had set up my own separate room. I had my own little rest room, break room that I could go to, where I could not only just give myself my injections, but I didn't have the stamina for a full school day when I first returned. So I actually had, they'd set up a cot for me to rest in. I could take breaks when I needed. I didn't have to get permission to take a break. I could just go to that room and rest if I needed it during the day. They accommodated my learning so that I didn't have to lose the year from having missed a term. So any assignments I hadn't done during the term, they just automatically assumed I would have done well and counted them as not counting. So I didn't have to worry about having missed those grades, and only counted the things that I had actually turned in. So anything that I had actually done counted. Anything that I missed completely, it's as if it had never been assigned. So they only counted the work that I was able to do. And in that way, actually graduated with my class. So everyone I had started school with, I graduated with, because the school just worked around what I was able to do, assuming that I could meet the milestones for the learning skills that were being taught for that grade. So as long as I could keep up in terms of my skills, they were fine with allowing me to miss assignments if I had to miss them, because I had to still spend so much time going back and forth to the hospital. As I explained earlier, I still had to go to the hospital every morning before school. So there was no question of my arriving on time every day. It just wasn't always possible. There was no issue of my not always having a late slip to say, yes, once again, I was at the hospital today. They were like, yep, that's just a thing you have to do, so it's fine. They completely understood that this was what my life looked like now, and they weren't going to make it any more difficult for me than it needed to be. So honestly, they could not have addressed this any more wonderfully. All of my teachers had been prepared. All of my teachers has helped me with any subject where I actually needed any kind of remedial assistance to catch up if I had fallen behind in anything. And so honestly, I think actually I laugh because the semester I missed, I think my average for the term that I missed was 90, just because there was only one grade that counted and it was a 90. So that was my average for the term that I missed. But the school really did think about how it was more important that I was able to feel embraced by the community and feel that they were accepting of me in whatever condition I was in when I came back to school, rather than following all the strict rules that may or may not have been in place. It was actually wonderful. I never felt othered. I never felt weird. I never felt like the fact that I couldn't walk when I came back and was, had knees bigger than my thighs because I'd lost so much weight and all of that stuff. I was never made to feel like I didn't belong in the school space that I was in. It was absolutely fantastic. I wish every school had that model, because honestly, people talk about high school as a nightmare. My high school experience, in part because of how they dealt with my chronic illness, was absolutely one of my best childhood memories. So there are ways.
And I would say that McGill, because I was a student back in the 90s, and now I'm on faculty, has made tremendous strides in terms of accommodating students with all sorts of situations. The Office for Students with Disabilities is a fantastic advocate for that. So Harleen, all of those accommodations are now managed centrally with the Office for Students with Disabilities. And I have to say, they are tremendous in terms of, and with respect to the pandemic per se, the nursing department has taken the stance where we are going to ask you to hand things in if you can. If you need an extension, we'll give you an extension. We don't really care, you know, because we are nurses first. And when I arrived in nursing school, chronically ill as I was like, but you people are different. Like, what do you mean I can have handed in whenever? They're like, but we're nurses. So they get it. So I think that's more and more spreading in terms of the accommodation of students. We have very, very strong allies and advocates in the OSD.
Hi, so name is Summer. I just personally want to say thank you so much for the panel and for Sloan and for everyone in the video who took the time to, you know, share their stories and just be so vulnerable and so open. It's so powerful, and I just want to say thank you. I guess my question comes from wondering about maybe the sense of grief that sometimes may happen between what you want to do and what you actually can do, you know, dealing with chronic illness, and how feelings of shame or inadequacy can come from that, and how maybe, you know, the intersectionality piece, your different identities and your race and ethnicity or your sexual orientation, your gender identity or religion can maybe exacerbate those feelings or mitigate that. And I'm just wondering how that process of developing compassion for yourself sort of, you know, developed, and how you've done that and how that process has been for you.
I went through a lot of different phases with my illnesses because I was diagnosed when I was so young, and a lot of the early news was not encouraging. The thing I struggle with most now is the fact that I recognize that I will be unreliable. There are times when I have plans and I really intend to be there for things, and then at the last minute, sometimes fairly late in the game, I am just not able to meet that commitment. And that's hard because there's so many things I want to do, you know, engagements I want to keep. I mean, even an event like this, you know, I sign on and say, yes, I'll be a panelist. And that's not a guarantee. I could just as easily have woken up today and it been like, that's not a thing I can do. And it's really hard to be in that position of wanting to be there for your friends, for your family, for your obligations, and knowing that you are just not the world's most reliable human with no control over that. It can be frustrating and frightening, but I would tell you that that's probably what I consider to be the worst part of having the conditions that I have, because as weird as it sounds, by and large, I still think my illnesses are more blessing than curse. And I say that sincerely, in that I learned so much through having these challenges. They've allowed me to see the world in a way that I don't think I would have if I didn't have these challenges, and to appreciate things in a way that I might not have if I didn't have these challenges. I think that being in this position so often has made me more compassionate. It's made me more understanding. It's made me appreciate that the people around me may have also have struggles that I'm not seeing. So to be accepting of everyone sort of doing the best they can in the moment, even if I don't necessarily understand why they're doing the thing they're doing. And so as much as it frustrates me some days to wake up and know this is going to be not my best day ever, or to have those moments where I recognize that I'm in so much pain, I literally can do at most maybe some breathing and perhaps making it to the bathroom, and that's pretty much what my day is going to look like. I still am not sure that I would trade what I've learned and gained through the struggle for not having to, like, in exchange for not having it. It's been an amazing journey. It's also prepared me for so many things. It's allowed me to advocate for other people who end up in the healthcare system because I know it so well. So when my mother had cancer, or when one of my best friends was hit by a car and ended up in a coma and needed someone to sort of navigate the complexities of the system for her, I had those skills because I'd been doing it since childhood. I mean, it has given me so many gifts that I'm willing to take the parts that aren't as easy to navigate in exchange. So yep, I would say honestly, just the fact that occasionally I'll promise to be there and then realize too late that I can't be there, that's the worst part. Everything else is just, you know, an experience to learn through.
I can go next. Adrian, thanks so much for sharing that. Yeah, the unreliability thing, like just like the grief over that. I just want to make sure, just because I'm so wrapped up in Adrian's answer, that I want to get the question right. Is it okay to repeat the question just to make sure I'm not just going off on a tangent from what Adrian said, that I'm actually answering the question?
Yeah. So I guess to make it more concise, my question was just how, like, with that constant battle between what you want to do versus what you actually can do, and sort of the shame and inadequacy, like feelings of those that can come from that, how do you develop compassion or learn to be gentle with yourself, you know, and just how that process came to be?
I think what comes to mind first is that it's not easy, and to let yourself almost be compassionate around not being able to be compassionate sometimes. And like, so I mean, this makes me think about my chronic depression and how 2 years ago, I finally got a medication that worked. It took about 3 months for it to kick in, and like 6 months for me to feel the full benefits of it. And I remember just being like, what? This is what people who don't have depression feel all the time. And I was just able to do so much more. And my 100% when I had depression versus my 100% now, it's like such a huge difference. And I feel resentful almost, and I'm okay with that. And I know when and still, because I still have other chronic illnesses and I still have episodes of depression, but I just want to share very honestly, like so many nights of just, or days of just crying and grief of not being able to go to this job that I love so much, or able to follow through on plans with family or friends, or go to events that I want to go to. I love to dance, I love music, I love art. I can't enjoy my life. And also that feeling of, like Adrian was mentioning, unreliability, like I'm not reliable. That makes me a bad friend, that makes me a bad sister, that makes me a bad student, that makes me a bad employee. It makes me a bad youth worker to my students, like all these feelings of, you know, just like horribleness. And then you know, like not being okay with, like, I'm not okay on those days that I can only brush my teeth and maybe not even brush my teeth. I am not okay with that. And so there's these moments of like, I think I need to really ground myself and tell myself that I am a human being, and you know, I also still have something to offer, and that it's okay if I can't love myself. You know, I can love myself and not being able to love myself. Like these like honest moments at night where I'm like, it's really hard to be okay right now and be okay with myself. But kind of this idea that, but I still do love myself. I still I think I'm gonna make room for that grief. I'm gonna make room for that frustration. And you know, that's like sometimes positivity culture can be really toxic for some people, where it's like you always have to love yourself, you always have to be grateful. And so making room for grief and making room for, I hate that I can't be there right now. And actually making room for that is gonna be just allowing you to have the feelings that you have, and allow you to be human and reacting to the chronic stuff you're going through. I make gratitude lists, but on some nights I make ungratitude lists. Like, I am not grateful for these things tonight, and letting myself simmer in that. But then being like, but you know, that's our system is not in place to accommodate the fact that I can't get out of bed, the fact that I can't, even the fact how sometimes with friend circles, I need to create a system with my friendship that I'm like, I can't hang out with you the way other people hang out with you, but can we do this instead because I really value our friendship? Or me telling my family like, look, I can't help you organize family events like birthdays or whatever, but it doesn't mean I don't want to be there and I don't want to help. So maybe I could do this instead. Or with work, just like this is more at a workplace level of like my workplace is so accommodating, and it's like your health first. How are you gonna serve your clients if you can't feel good coming into work? If you don't feel good, stay home. And that helps me be more compassionate to myself, because the system is not telling me to hate myself. So almost my solution is again, the systemic, but also like making room for being frustrated and being having compassion for not having compassion.
I think one thing that some people with chronic illness, myself included, end up doing is that given the, this perception of unreliability, right, that we don't like, we tend to do stuff that someone who only had this once would not do. For example, like I go to work as a nurse with a boot on my foot because I have chronic stress fractures in my feet. So any other nurse who has a boot on their foot would be off on their bum at home with their foot in the air. And I'm like, no, I'm gonna come to work because I always have a stress fracture, right? This is just the way I am. And so if I didn't go to work with a stress fracture, I would never work. So I think that, and then do you go to the gym if you're short of breath? Of course you go to the gym when you're short of breath, or else you never go to the gym, right? I've gone and done a nursing shift with a bag packed in my car, knowing I'd end up at a merge at the end of my shift because I didn't want to leave my colleagues short-staffed on a weekend. And then I left one hospital and went to the other. So we do stuff that other people are like, why don't you just sit home? I'm like, well, because then I'd always be sitting at home. So, and then that, call it therapeutic non-compliance. But we get into trouble sometimes as a result of doing that. In the pursuit of normality, but and then you just have to have clinicians who are like, what did you do now? Yeah, okay, fine. We get it why you did XYZ, and maybe that wasn't like the wisest thing to do. Like, oh, you're a mad asthmatic and you adopted 2 more kittens. Oh, okay, fine. Because life, right? So yeah.
Well, thank you so much, everyone. And thank you, everyone who stayed to the end, because I know that we did go over time. So I really appreciate that. We just want to thank our panelists for their amazing insight and everyone for coming today. Sloan let me know that this took 10 months to make the film and then 8 months to sort of get this event underway with COVID-19 and everything going on. And for her, it's 2 o'clock in the morning right now. So I think it's good to wrap this up. But yeah, I'm really grateful for everyone for coming out today. And to learn more about sharing stories, forming communities, and challenging stigmas, please do check out the Thrive Collective and medicalherstory.com. You can also find us at the Thrive Collective McGill and at Medical Herstory on all our social media. And with that, we're going to wrap up the event today. But I do encourage you that if you didn't get a chance to ask your question, I know there's a few of you, please jot them down in that shared Google Doc. And some of us will take a look at that later, and feel free to keep that conversation going there. And we'll keep you posted about the Thrive After Party on our Facebook.